Welcome and thank you for joining us today for the webinar on policy approaches to achieving equity in cancer pain management. My name is Bryce Geiling and I'll be your WebEx host. Before we get started, I'd like to make a few housekeeping comments. All lines have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions through the presentation in the chat or Q&A panel and select all panelists from the dropdown. Since there are multiple speakers, please indicate which presentation you're addressing in your question. We will ask that the questions on your behalf during the Q&A portion of the webinar. If you need to view live captioning, please refer to the media viewer panel or the link that will appear in the chat panel momentarily. And lastly, please note that this webinar is being recorded. And now I'd like to turn it over to Dr. Acevedo to introduce the speakers in the webinar series.
Welcome to the Achieving Equity in Cancer Pain Management webinar series. In December 2019, the Cognitive, Affective, and Social Processes in Health Research Interest Group, or CASPR, hosted a meeting on cancer pain management disparities at the National Cancer Institute. During that meeting, it became clear that bridging the divide between basic and applied research in the cross-cutting transdisciplinary area of cancer pain management disparities would require more time and tangible forms to foster. Soon after the conference, the COVID-19 pandemic and continued instances of police brutality made it all the more important for researchers to put more effort into studying health inequities and the various ways in which institutionalized racism contributes to these inequities. To that end, my co-moderators, Drs. Rebecca Ferrer and Sandra Mitchell, along with members of the CASPR group, Drs. Jamie Arndt and Angela Bryan, planned this webinar series to delve deeper into the complex ways in which inequities in cancer pain management arise. The second webinar in our monthly series will focus on policies that impact equity in cancer pain management. Today, we have 3 speakers, 2 with clinical and scientific expertise in cancer pain and symptom management, and 1 with scientific expertise in the area of policy implementation and dissemination science. Our first 2 speakers will describe specific policies that may contribute to inequities in cancer pain management, and our final speaker will describe how dissemination research can help promote equitable policies related to health. Our first speaker, Dr. Salima Maghani, is a professor of nursing and term chair of palliative care. She's also the Associate Director of the New Portland Center for Transitions in Health and Senior Fellow of the Leonard Davis Institute of Health Economics, all at the University of Pennsylvania. Dr. Maghani's scholarship has contributed to an understanding of sources of disparities in cancer pain and symptom outcomes among at-risk populations, including racial and ethnic subgroups. Dr. Maghani was a past chair of the American Pain Society Pain Disparities Shared Interest Group, and currently serves on the editorial board of Pain Medicine and Nursing Section Head for the Journal of Pain Research. Dr. Maghani has served on the National Academy of Medicine committees, including Dying in America, and more recently on pain and symptom management for people with serious illness in the context of the opioid crisis. Without further ado, Dr. Maghani will share her expertise with us in her talk titled The Opioid Epidemic in Cancer Pain Care, Lessons from Converting Policies into Practice. Dr. Maghani.
Thank you so much, Dr. Acevedo, for this kind introduction and for NCI to be hosting this very important webinar series. So I'll share I have no conflicts of interest. I have these disclosures and funding sources, and I'm happy to conflict with NIH some more. So this is my presentation outline. I will start with the larger context of overdose crises in the United States, discuss some key policies, and I will be specifically focusing on the CDC opioid guidelines that Those were published in 2016, and those are very critical in shaping the current pain practice. And the lessons that could be learned from the 2016 CDC opioid guidelines, and that is very timely because the new set of guidelines are expected either in 2021 or 2022. And finally, I will situate equity in cancer pain management within this larger backdrop. So as some of you may know, Watch published a series of reports from countries like India, Mexico, Armenia, identifying and bringing to light horrifying state of pain relief in these resource-poor countries. More recently, Human Rights Watch reported that the same horrifying stories are now coming from pain patients in the United States. So this hardware actually came out of a chronic pain patient who was very rapidly tapered, essentially rendering her bedridden. As some of you also know that in 2016, the CDC opioid guidelines for chronic pain was published, and the guideline had 12 recommendations about when to initiate or continue opioids, opioid selection, dosage, duration, and discontinuation, and assessing risks and harms of opioids. Three things to note here is that the guidelines were meant as voluntary. They were meant for primary care clinicians as well as for chronic pain. So I'll preface by saying that the guidelines were well-intentioned, but they were broadly misapplied across sectors. I present article metrics here to show that the guide you who are familiar with altmetric score, this is the highest scoring output from CDC and one of the top from JAMA of all time. And as a context, also that the guidelines were characterized as low quality using great methodology that the article authors fully disclose in their publication. 84% of the 31 outcomes studied, such as abuse, overdose, fractures, MI, etc., had type 3 or type 4 evidence, and 16% of outcomes had insufficient evidence, that is, outcomes relating to long-term use of opioids, pain, function, and quality of life. So already 5 months into the guideline publication, there was an indication of misuse of the opioid guidelines by the insurance companies. And this is a comment that was published in response to the CDC opioid guidelines in JAMA, where this clinician essentially received 8 letters. In fact, the clinician says 8 more letters from an insurance company asking the clinician to complete forms because the insurance company, the prescription exceeded 50 morphine milligram equivalent dose per day, which was one of the cutoffs that was recommended by CDC for cautious use. And then CDC also recommended 90 morphine milligram equivalent, avoiding to use that dose. By 2017, several major insurers and payers were already had already implemented various policies limiting opioids. So you could have a prescription of opioids by your provider. However, these insurance companies would still decide not to fill those prescriptions. And as the Health and Human Services Interagency Pain Management Guidelines indicated, these misapplications, some of the misapplications apply to cancer patients as well as patients receiving palliative care. Some of the examples of the measures, and I'm not necessarily saying that all of the measures were necessarily misapplications, but these are some of the measures that the insurance companies took. For example, not covering certain opioids, reducing significantly percentage. Anthem reduced opioid prescription by 30% 2 years ahead of the schedule. And that Medicare Part D required that sponsors consult with providers, with prescribers for any orders exceeding 90 morphine milligram equivalent per day. As you recall, the CDC guidelines were meant as voluntary. But at least 33 states had enacted laws with some type of a limit on opioids. And majority of these laws were published after or enacted after 2016. And just to draw your attention to the morphine milligram equivalent dose limits, the hard limits, which resulted in patient dumping and involuntary tapers. So this was a study which was conducted in Vermont, and this study is of Medicaid patients. So these are our patients who are poor, and the insurance serves at-risk population largely. These were the patients who were receiving more than 120 morphine milligram equivalent dose of opioid per day for at least 90 days. The median time, and this is a very important point, the median, which essentially means that half of the patients received no dose reduction of their opioids. And just to remind you that these patients were receiving high dose opioids. Less than 1% of patients were transitioned to opioid use disorder treatment. And then this graph also shows that rapid discontinuations were associated with the highest rate of adverse events, and majority of these tapers occurred in 2016, 2017. And as it could be predicted that with the misapplications, I should say broad misapplications, the rate of overdose deaths actually increased 10% since 2016. 2017 saw the highest number of drug overdose deaths on record, and this is prior to COVID-19, which further worsened the epidemic. Also less appreciated is that the largest percent change, so this is percent change, was in opioid involved deaths, was in patient black persons. So on this graph, I would like to make a few key points. So first, I would like here. So I'd like to draw your attention to trends in cocaine and heroin and prescription opioids. So as you can see here, in 2018, the cocaine, heroin, and prescription opioid epidemics converged. However, we never hear in public discourse about a cocaine epidemic. The second point to note is that this blue line is your prescription opioids. And at least since 2011, these trends have largely remained either decreased or largely remained constant. And even before 2016, the opioid epidemic was mainly driven. And there is, you can see the slope, and you could predict that the main driver of the so-called opioid epidemic is illicitly manufactured fentanyl. And these are not prescription opioids. And the other contributor to opioid epidemic is heroin, which is also not prescription opioids. So the majority of opioid epidemic is being driven by illicit sources of opioids, and this is a trend that was before 2016. And these are not your prescription opioids. But these perceptions are makers and clinicians. This is a poll result from IQVIA webinar just only a month ago, and this is heavily attended by academics and policymakers. And this is an attendee poll to this question: what do you think is the most important issue in opioid crises? Majority responded that misuse of prescription opioids is the most important issue, well above access to medications for opioid use disorder, which is a significant national issue. I think that would be considered a crisis, lack of access to medicines for opioid use disorder. Of note, illicitly manufactured fentanyl, which is the main driver of opioid crises, was not even presented as an option, as a response choice. So I think I wanted to make a key point on this slide that I think we need correct vocabulary in public discourse in terms of teasing apart the licit and illicit sources of opioid, the so-called opioid epidemic. And as the past president of AMA in the same IQVIA webinar said, that we have an overdose epidemic. The different trends. So I will switch gears now to talk more specifically about the misapplication of the CDC opioid guidelines to patients with cancer and those receiving palliative care. This is the 2019 Health and Human Services Interagency Pain Management Task Force, and they specifically investigated the CDC opioid guidelines. That was one of their charges, and they found that the guideline was misapplied broadly, as well as to patients with palliative care and cancer. Just as a backdrop, the CDC guidelines excluded 3 groups of patients from its scope: those patients who were receiving palliative care, those at the end of life, as well as those patients who were receiving active cancer treatments. As explicitly stated here in the published guidelines, cancer survivors were included as part of this scope. In our JAMA Oncology article that was published in 2018, we brought attention to several issues that caused discrepancies, either actual or perceived discrepancies in the published oncology cancer pain management guidelines and CDC. The arbitrary scope of the guidelines, the perceived discrepancy with other national pain guidelines, and simple lack of feasibility of some of the recommendations to be implemented in practice. So this is a longitudinal study, a 1-year longitudinal study from American Cancer Society of about 5,000 patients. And it found that there was no difference in pain between patients who were receiving active cancer treatments such as chemotherapy or radiation therapy versus those who had completed cancer treatment. And this makes sense because about 1/3 of cancer patients develop pain as a result of cancer treatments that they receive. So after the publication of our article in JAMA Oncology, I received an email from the CEO of the National Comprehensive Cancer Network, Dr. Bob Carlson. And he said, your article has not gone unnoticed. And we applauded that the leadership of the NCCN and the American Society of Clinical Oncology promptly responded with a joint effort that led to a meeting with the leadership of leadership of CDC Cancer Control Program, including Dr. Deborah Dowell, the primary author of the CDC opioid guidelines, and the then FDA Chief Commissioner, Dr. Scott Gottlieb. Dr. Pace went over at the last NCI webinar, the first webinar, Dr. Pace went over this matrix. And so I will not go into the details of it, but I would like to draw your attention to these. So essentially this matrix identifies different guidelines that are available for cancer pain management. And these guidelines, both in terms of the audience as well as the scope of the guidelines. As you can see, the CDC guidelines and the cancer survivorship guidelines, the ESCO guidelines, both include patients who are cancer survivors. So they exclude patients who are receiving active cancer treatment, but they include patients with cancer survivors. However, the audience for the CDC guidelines were primary care clinicians. So in essence, you can't have two sets of guidelines for those cancer survivors who are managed by PCPs versus those cancer survivors who are managed by oncology clinicians. So oncology clinicians is that in response to this joint effort by the National Oncology Societies, in 2019, CDC issued a key clarification that professional society guidelines should be followed to manage pain in patients with cancer, which was a very important clarification. The actual, or I should say the formal clarification on the CDC opioid guideline misapplications was not published for more than 3 years after the publication of the guidelines. So this is an interview quote from Dr. Francis Collins, which underscores that even though we would all love to set aside opioids and replace them with something else, we are not there yet. And we need to take care of the individuals who need opioids to manage pain and maintain function. So this is my perspective. This is CDC's campaign to fight the opioid epidemic. Again, well-intentioned. But some of the messaging could who absolutely need opioids to manage their pain or maintain their daily function. So their messaging such as it only takes a little to lose a lot without qualifying that there are patients who need these medications. I'm having a hard time trying to go to the next slide. Sorry about that. All right, so these are quotes from our recent American Cancer Society funded study of patients receiving active cancer treatments. As you can see in this word cloud, pain relief was the top concern for these patients, but they constantly felt the need to justify using opioids for pain. As this patient said, I do not use them. I have them there for mental backup, so that if I feel that I'm in a real bad situation, then I have my medicines right here. This other patient said that I was literally trying to see how long I could go between pain pills. I mean, it was just stupid. In our recent paper, we reported on unsafe opioid self-management practices that patients engage in to limit their use of opioids, such as cutting pills, self-tapering, mixing a cocktail of over-the-counter non-opioid analgesics, acetaminophen and NSAIDs, and using around-the-clock opioids on an as-needed basis. And one phenomenon that has not received due attention in cancer literature is how gaps in opioid use can potentially predispose patients to overdose risks and potentially due to reduced opioid tolerance. So we recently reported that 1/3 of patients had 7 or more days of gap between consecutive doses of long-acting opioids. And these data were from before the 2016 opioid guidelines. We used a newer method to look at these data. But I can only imagine that these patterns must have worsened in the recent days. In a previous analysis, we found that the interaction of inconsistent opioid adherence patterns with strong opioids for unplanned hospitalizations among outpatients with cancer, and that African Americans were 3 times more likely to have inconsistent analgesic adherence. And we have published, and other independent authors have published on opioid adherence and racial disparities in opioid adherence, and these data are very consistent. At-risk populations, and especially Blacks, also have the strongest risk factors of experiencing multiple other sources of inequities, such as provider bias. And we have reported this across many studies, and these further compound disparities. So switching gear a little bit, the number 1 of the 12 recommendations of the CDC state that non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain. However, this recommendation cannot be implemented in practice. So these are preliminary data from our current R01 study with cancer outpatients. And as shown, patients largely do not have access to treatments, even though I think we talk about multimodal treatment a whole lot, but in practice, patients don't have access to these treatments. So both Blacks and Whites reported very low access to cognitive behavioral therapy, and 15% of Whites and only 3% of Blacks report using acupuncture. And there are also significant out-of-pocket costs associated with integrative treatments such as massage and acupuncture. This is a statistic from the national average cost of acupuncture. And just to add that this disproportionately disadvantages vulnerable and poor patients who have pain. This is to show that Medicare does not cover acupuncture for any other condition outside of low back pain. And this indication, it started covering acupuncture for this indication only last year. So in our JAMA oncology article, we argue that successfully promoting a paradigm shift towards non-opioid, non-pharmacological necessitates reliable, affordable, and consistent patient access to evidence-based, multimodal, non-opioid pain treatments. And that this need should be voiced clearly in the emerging policy debates that propose to largely substitute the current pain management paradigm without first adequately supplying another. So with that, I'll just list some key policy targets to improve care of patients living with cancer pain. So the first, I believe, is low barrier and equitable access to cancer pain care, both opioid and non-opioid, as necessary for the correct patient population. Require insurers to make evidence-based non-pharmacological interventions reliably and consistently available and paid for. Major payers, including Medicare, should cover acupuncture and other evidence-based pain treatments. And I should add Medicaid, because that is an insurance that takes care of our poor and at-risk populations. And reduce burdens such as pre-certification requirements that disproportionately affect at-risk groups. Telling slide where I side-by-side showed how the counts of patients who are minorities are so much different in terms of access to opioids than some of the experiences of our white patients, because the white patient said that it has never occurred that I didn't call and get whatever I needed. And the Black patient articulated significant barriers to accessing insurance opioids because of the pre-certification requirements. And she said that sometimes pain occurs over the weekend and you cannot get a refill without having to go through pre-certifications. Reduce stigma and address lopsided models of accountability. So the scope of opioid stewardship programs, there are a number of opioid stewardship programs that have been implemented across health sectors. And the scope largely of the current opioid stewardship models are to limit opioids. So that's the code word essentially for limiting opioids. And I'm recommending that outcomes such as pain function, reducing stigma, in improving access to non-opioid treatments and access to medications for opioid use disorder in an opioid use disorder, inappropriate tapers, and reducing pain care disparities beyond prescription MME limits should be part of these benchmarks for tracking. And that equity should be tied to quality and tracked as quality benchmarking. And this can also address implicit biases. And I can explain how in the Q&A if that question arises. And this is an important one, that future pain guidelines and policies should have a plan that anticipates and addresses foreseeable inadvertent risks to patients, public, and subgroups. So the CDC opioid guidelines obviously pertain to a very large segment of our population that suffers from chronic pain, about 30,000, about 30 million Americans. So it could have been anticipated that the guidelines will have very wide and far-reaching implications for a sizable segment of our population. And then being nimble in calling out and addressing any misapplications, assessing and being vigilant about balloon effects. And the guidelines should be in harmony with guidelines, and that the key recommendations should be feasible and practical in the clinical setting. So with that, I would like to end with this thought from Yogi Berra that I interpret as correct policy directions require correct policy questions. Thank you.
Thank you so much, Dr. Magani, for your presentation. I think we're going to move straight into Dr. Marmo's presentation and reserve any questions that came up for the panel discussion at the end. So our second speaker today is Dr. Suzanne Marmo. She is an advanced certified palliative hospice social worker and has been a licensed social worker since 2001. Her clinical expertise is in medical and oncology social work, hospice, palliative care, and working with older adults. She's a member of the Social Work Hospice and Palliative Care Network and helps to coordinate the Sacred Heart University Interprofessional Palliative Care Committee. She has co-developed and teaches a graduate level course entitled Life, Loss, and Transition to Social Work Students and serves as a mentor to new palliative care social workers. Her research interests include the role of hospice and palliative care social workers and organizations, political palliative care social work, and social justice and equity in palliative care. Dr. Marmo will now share her expertise with us in her talk. Dr. Marmo.
Okay, got my kids off the screen. Okay, you can hear me okay, right? Okay, thank you very much for that introduction. Just to clarify, I am not an associate professor. I am an assistant professor. Did not get tenure yet. That's coming up next year, hopefully. I am both a clinician and a professor now. So I spent 20 years in the field practicing social work. And now I have moved into, in the last few years, into research and academics and teaching other social workers. So I'm really happy to talk today about something I'm very passionate about, which is structural inequity and cancer pain management, and specifically coming from a social work perspective. Okay, so today we're going to learn about intersectionality, and utilizing the intersectionality framework, we're going to describe how healthcare policy contributes to disparities in cancer pain management. Then we're going to also describe how US healthcare policy might be improved with a total pain approach to cancer pain management, and also identify barriers to cancer pain management in terms of utilization, bias, access, and affordability. And finally, because I am a social worker and I want to do something about this, I also want to encourage people to engage in political advocacy and engagement, and how that can be accomplished by the everyday practitioner. I'm going to start off my presentation with a land acknowledgement. This is something that is done very often at workshops. I'm sure some of you may have experienced it. And now we're on Zoom, WebEx today. And it's a little more difficult to do that because we're not all in the same space. So I'm just going to acknowledge that as we gather in this virtual space, we acknowledge that the grounds we occupy are historically the home of Indigenous persons who have been forced to leave their land. I'm coming at you from Long Island, New York, and I acknowledge that the land beneath my feet is stolen land and was known as Setauket land, home of the Settlecut tribe. I also acknowledge, and I'm going to start off this presentation, that persons from most Indigenous tribes experience inequity in cancer pain management, and I'm going to draw attention to these inequities today first. So Native Americans are less likely to have access to specialty pain management, very often living in rural areas far away from specialty cancer services and pain management. So therefore, they're more likely to also, when they get very sick, be in hospitals away from their homes. They're also less likely to discuss cancer pain with medical providers, and also less likely to have cancer pain effectively managed, and also experiencing spiritual competence in cancer pain management. So why am I here? I am here because I am a social worker and I am a researcher. And something that I noticed in my social work career when I was working with cancer patients and when I was working in palliative care and hospice was that social conditions very much determined the level of care that you got and the outcomes that you were that occurred for a cancer patient. So my practice experience exposed me to something called social determinants of health, and I didn't know what it was at the time because the terminology hadn't been put into the research. But for those of you that don't know, social determinants of health are differences in health outcomes that are closely linked with social, economic, and environmental disadvantage, and are often driven by the social conditions in which individuals live, learn, work, and play. So social determinants of health, as I moved into the research side of my career, I witnessed that not only in my practice micro experience, but also in the research reflected that social determinants of health determine outcomes for people with cancer. The social groups you are part of, where you live, and Medicare coverage for pain management and end-of-life care is not adequate to correct these social inequities. And most of all, what was so upsetting in the practice world, and as I see also in my research world, is that some people die with more suffering than others. And that is something that as a social worker, the last piece is the National Association of Social Work, our national organization code of ethics, states that social workers should engage in social and political action to make sure that all people have equal access to meet basic human needs. And pain management does fall under a basic human need. So I am obligated by my profession to do something about this. I actually am looking into this a little bit more, and I have checked nursing code of ethics and medical code of ethics and chaplain code of ethics, who also have similar mandates within their code of ethics. So when we start thinking about what shapes cancer policy in the United States, we can right away point to Medicare spending. For cancer treatment, Medicare is the primary payer for these services. And not only is it the primary payer, about 55% of all cancer services, cancer spending comes from Medicare. It also sets the standards for all other private insurances pretty much. Most private insurances will look to Medicare for the guidelines for coverage. So policy decisions made within the Medicare system are really important because they tend to set the standard of care for non-Medicare patients as well. And so if we look at distribution for Medicare fee-for-service expenditures, we can see that the majority of spending is on physician services. The darker blue is cancer care, on physician services, on inpatient hospital and outpatient hospital. And the less care is given to, the less amount of spending is to how we actually take care of people and help them. So much less to home health, skilled nursing facility, and hospice. Most of the cancer care spending is going on a per visit fee-for-service spending. Okay, so systemic racism happens in healthcare, and that can lead to inequity in healthcare. And this occurs on the basis of socioeconomic status, race and ethnicity, gender, sexual orientation, and other factors. And of all of these factors that can influence the outcomes of cancer care, the disparities based on race and ethnicity are usually the most persistent and difficult to address. So this brings us to an intersectionality framework, which will ask us to examine these inequities in forms of diverse and intersecting social identities. So being part of one oppressed group and marginalized group will make it more likely that you're going to experience inequities in pain management. Being part of two targeted marginalized groups will make it more likely that you're even more so. So intersectionality is a term that was first coined by Kimberly Crenshaw back in 1989. And put simply, it's the concept that all oppression is linked. Everyone has their own unique experiences of discrimination and oppression, and we must consider everything and anything that can marginalize people: gender, race, class, sexual orientation, physical ability. Okay, and these social identities combine to create different models of discrimination and privilege. Okay, so cancer pain facts. Approximately 60% of cancer patients experience moderate to severe pain during cancer treatment, and over 30% report persistent chronic pain months and years following treatment. Amongst these pain experiences, people from BIPOC, Black, Indigenous, and people of color communities experience greater pain intensity, this is what the research tells us, greater pain-related disability, and a lower likelihood to have an accurate pain assessment. Lots of research studies have shown that people of color, Black, African American, and Hispanic, and women for that matter, are often underestimated in the amount of pain that they are actually experiencing. And also, research on inequities in pain management tends to measure what we call physical suffering. Now, for those of us in pain management and palliative care, we recognize that pain exists on many models: spiritual pain, emotional pain, social pain, physical pain, okay? And that brings us to the total pain model that is the basis of palliative care and hospice. And Dame Cicely Saunders defined the concept of total pain as the suffering that encompasses all of a person's physical, emotional, social, spiritual, and practical struggles. And for those of us that have worked in the field with patients, we know that each one of these factors influences the other. So you can't treat one without treating the other. So that's the philosophy of palliative care and hospice and pain management, that we're going to put an interdisciplinary team in there to be able to tend to all those needs. Okay, so the total pain model, unfortunately, your research and your policy tends to put primacy on physical pain and not necessarily the total pain model. So when we look at this, we can look at a cancer patient's perception of total pain. This is from a assessment and treatment of pain in the terminally ill, that a patient can experience physical pain, can experience emotional pain like anxiety, can have interpersonal strains, family strains. These are all things that can happen through the cancer experience, maybe financial problems, and also spiritual pain. But when we look at how fee-for-service medicine reimburses this, which really does drive policy in cancer pain management, we find that physical pain, that's probably going to get paid, okay? Anxiety, rage, and depression, that might get paid, okay? So now I am a licensed clinical social worker. I can bill, but to bill for services, I have to pathologize someone. I have to say they are suffering from a psychiatric diagnosis. And sometimes cancer patients aren't depressed. Sometimes they're just having difficulty. Maybe they're not suffering from major depressive disorder. Maybe I need to work with them on strength perspectives. And that doesn't necessarily trigger billing. And then definitively for family strains, for social support, that is not going to be paid by fee-for-service medicine. And that tends to be a barrier to care management. And definitively, they're not going to pay for spiritual pain, which can really impact a pain and needs more attention in the field. So barriers to effective cancer pain management occur on the personal level. As Dr. Magani spoke about, a fear of addiction and a lot of that, being some misinformation out there, a fear of the side effects and lack of knowledge about pain medication. It can also happen on the provider level, where the doctor just doesn't ask about pain, or the provider is uncomfortable talking about pain. Now, I think we definitely have grown in the field about addressing pain, but perhaps maybe not the total pain, okay? And there also is a racial and gender bias that we see from providers about underestimating pain. On a systems level, we often find inadequate or no insurance coverage is a barrier to effective pain management, okay? High costs and financial toxicity experienced by cancer patients, and also drugs are just not available at all pharmacies. Okay, so when we have these barriers in cancer pain, it creates different experiences in cancer pain. So these differences in cancer pain lead to poorer outcomes experienced by disadvantaged groups. So I want you to think about differences. And when there are differences and there are poorer outcomes, they become disparities when these differences are avoidable and unjust. And these conditions are social conditions, social constructs very often based on where a person lives or how someone is perceived. And they are avoidable and unjust. And that's why these are disparities and not just differences. So disparities in pain management, I'm going to go over some examples of this, including utilization, bias, access, and socioeconomic. I have a shout out here to my SHU MSW class of 2021 and 2022. About a week and a half ago in class, I said, listen, I got to do this big presentation, and I need some statistics that are going to show people that disparities exist in pain management. Will you help me out? So I turned it into a lesson about how micro practice, individual practice, is really influenced by the macro world of policy. I left the room for 15 minutes to go get a cup of coffee. I said, do your research, I'm going to come back. I came back. 2 of my classes provided me with spreadsheets full of documents and statistics. And this is a lot of this is from my students. Okay, so what we know about utilization is that disparities in pain management. Black and African Americans are more likely to be diagnosed with cancer and more likely to delay medical care. And what we know about that is the later you're diagnosed in your disease process, it's more difficult to be able to manage your pain. Persons from BIPOC communities report concerns, have mistrust, or feel they lack enough knowledge to speak with their oncologists about pain. Also, some research has shown that persons from marginalized communities worry that advocating for their pain with their oncologist might distract their physician from treating their cancer, so they just delay doing that. And when we move into the hospice world, which I'm going to speak about a little bit more in a few minutes, despite the continued use of hospice for cancer patients, current hospice patients reflect 82.5% Caucasian, 8.2% African American, and 6.4% Hispanic patients enrolled in hospice. And that's a disparity that really hasn't changed very much in the recent years. And if we want to reflect on what United States population is, the United States population is approximately 60% Caucasian, 12% African American, and 18% Hispanic. So we can see a really big difference here on hospice utilization. So disparities in pain management bias, okay? Dr. Megani spoke about this, that providers often have bias against certain marginalized groups. And we see in the research literature, Black Americans, Hispanic Americans, Indigenous persons are systematically undertreated for their pain relative to white Americans. And systemic racism in healthcare is perpetuated by enduring false and racist beliefs. A study done just in 2016 of residents and medical students found that they had false understanding about pain, rating Black patients' pains, and they rated it lower and they made less accurate treatment recommendations, actually believing false ideas such as Black people's skin is thicker or Black's nerve endings are less sensitive. And when they held these false beliefs, they were less likely to make an accurate pain assessment. So we also have disparities in pain management due to access. As I was saying before, sometimes they're not even able to get the pain medication that they need. So again, as I was saying before, persons with cancer from BIPOC communities are likely to be given prescriptions for pain medication. And if they are prescribed, they tend to receive lower quantities. So here's another one that's kind of not really understood sometimes, is that your neighborhood pharmacies in BIPOC communities stock significantly fewer opioid medications. So it's going to be hard for people to even find it if they're prescribed it. And that's due to concerns about theft, about safety. And so it might be more difficult in these communities to find opioid medications. So higher numbers of Black patients and Hispanic American patients report obstacles in accessing pain specialists. So if an oncologist is going to refer me to a pain specialist, they're going to have some of them are reporting difficulty finding and accessing a pain specialist. And availability for pain specialists or palliative care is really dependent upon where you live, if you have insurance, socioeconomic status, and level of medical literacy. Do I even know that there's another option to help me with my pain? Okay. So when we get into disparities in pain management, we see a lot of it is due to socioeconomic status. The average out-of-pocket cost for cancer patients is $4,727. And let's think about Medicare for a minute. So for every 12 Medicare dollars that are spent, $1 of it is spent on cancer care. So in healthcare, it gives an incentive for physicians to provide more treatments because payment is dependent on the quantity of care rather than the quality of care. So this puts people from lower socioeconomic status at a higher disadvantage, because when you're dealing with fee-for-service medicine, you have a lot of out-of-pocket costs. So co-pays per provider per visit. If you're seeing your oncologist, perhaps maybe that's a $40 or $50 copay. And then that oncologist refers you to a pain specialist, $40 or $50 copay. And then maybe that person refers you to a palliative care physician, $40 or $50 copay. And we're not even talking about any of the other specialists that might be involved and the other co-insurances and premiums, deductibles, and medication. Medication isn't always covered. Although Medicare Part D did help with coverage, it also put something in place called the donut hole, which provides about a large gap in pay for medication that can actually make access really difficult. So there is one healthcare policy that isn't fee for service, and that's the hospice Medicare benefit. Okay, so there's no fee for service. This is not fee for service in hospice. The goal of hospice is to decrease suffering with a total pain approach and utilizing a specialized interprofessional team. So hospice does have its issues, okay, and I will speak about some of those today. But I would argue maybe we don't need to replace hospice with palliative care, which seems to be the trend. But we have to maybe just improve hospice as well. Okay, Medicare hospice benefit was established in 1983 under the Tax Equity and Fiscal Responsibility Act. It was shaped by a demonstration project that involved all advanced cancer patients. So the way Medicare hospice has been rolled out is really due to that demonstration plan. The benefit provides on a per diem basis rather than fee for service. So hospices earn a certain amount of money for every day someone is on the program. And there's also an interdisciplinary team mandate for hospice. It's the only service like this that says you can't call yourself a hospice unless you employ a chaplain, social worker, doctor, and nurse. Okay. So hospice has changed since the beginning of time. I worked in hospice in the mid 90s, okay? And we see a real shift in the hospice industry that happens, which has been referred to as the marketization of hospice, related to what Mimi Abramowitz calls the managerialism in human services. So between 1989 and 2009, 1 in 5 hospices closed. I remember when I worked in the field, there's all these little hospices that people could choose from. The trend, as in most of healthcare, is to move towards larger healthcare organizations. And there was a shift in the tax status of hospice. In 1990, 5% of hospices operated on a for-profit basis. 2018, that was up to 67%. That changes the industry a lot. Okay, so federal hospice and palliative care. So your Medicare hospice benefit was groundbreaking, and it was the first time specialized end of life care became a federally funded benefit. It also mandated the interdisciplinary team. But for palliative care, there's no similar benefit for palliative care on the federal level. Palliative care is treated as any other specialty service like cardiology or consultation service or dermatology. Palliative care primarily uses a fee-for-service model, and there's no mandate in palliative care with palliative care teams for an interdisciplinary team. Lots of palliative care teams will utilize an interdisciplinary team, but there's no mandate. Some Medicare expansion programs, like Medicare Advantage programs, are increasing the utilization of palliative care, but they are inconsistent and they're lacking standardization. So implementation of federal policy enables the United States to meet the needs of and the highest cost of patient populations. Okay, so I want you to think about a little bit. I wish I was actually here and I could ask questions with people, because I would like to just have you think about for a minute when you think about hospice. And so what we know about hospice is someone needs to be 6 months or less if they want to be admitted. They need to suspend curative treatment. And also that there's a clear distinction between hospice and palliative care. I want you to think about those 3 things. Why is that? Okay. And also this does put up a barrier for specifically cancer patients, specifically with the suspending curative treatment. So for cancer patients to take advantage of the services that are available on hospice, they have to say that I'm going to stop curative treatment. And that is shaped by United States healthcare policy. 6 months or less to be able to go on hospice is a creation of that first policy and of that first demonstration project. That doesn't exist anywhere else in the world. The requirement to suspend curative treatment, again, a United States policy based on that first demonstration project. And nowhere in the world will you find a clear distinction between hospice and palliative care. That hospice is for end of life and for people who have decided to stop curative treatment. In other parts of the world, there is no distinction. And if there is a distinction, hospice is just known as a physical place. Okay, the Medicaid hospice benefit has been changed on the federal level. And in some states, they do allow 6 months or less, like Kentucky is 6 months or less, like the Medicare benefit. In New York, under the Medicaid benefit, they have expanded it to 12 months in a few other states as well. The Affordable Care Act on the federal level did include a provision to change Medicaid hospice to all those under 21 do not have to cease curative treatment to be eligible for hospice. So they can still receive hospice. So I don't understand why at 22 years old you can't do this anymore, but that is the federal response to that. So trying to change hospice on a federal base is really slow. And we know that changing federal policy can be really slow. We have this one act that's been pending in Congress and died in Congress in the 116th Congress. And good news is it is supposed to start over again in the 117th Congress, the Palliative Care and Hospice Education and Training Act. But there's a lot of problems with that. But the federal government can do things very quickly, as we noticed by the Telehealth Services During Certain Emergency Periods Act, where they implemented it in 3 days, passed House on the 4th, passed the Senate on the 5th, and was signed into law on the 6th. They are capable of moving quickly. They just don't very often, because very often there's a lot of gridlock. So a way that is suggested by Diane Meyer from CAPC is to focus maybe perhaps from the bottom up, focus on state laws. State laws require a balanced budget, and they may be more open to cost-saving and time-saving alternatives. And if we can get on the state level changes that improve palliative care delivery, if that can be evaluated, that can be very convincing to other states. Okay, there is something in development right now to help people who want to advocate for state policy changes in cancer pain and in palliative care. And that includes a database that's being put together right now at Yale Law School, the Solomon Center, in coordination with CAPC. My social work students have been helping out with that, helping research, and CAPC has identified the need to improve access to palliative care with policies related to workforce payment, quality standards, clinical skill building, public awareness, and most recently, telehealth. The projected completion date for this is going to be summer to fall 2021, and it will be a state-by-state database that people can see what policies are pending, and then organize advocacy campaigns around that. One thing that was not identified by CAPC as a need for policy is the need for political action in addressing a social justice concern. So current cancer pain management and palliative care unfairly advantages chronic and terminally ill people with large caregiving supports, higher socioeconomic status, stable insurance coverage, and white identities. And that was discussed in a paper that I did, which was a policy analysis. I am going over a little bit, so if I can keep going, I'll just go into like, now what can you do about this? Okay, so one of the things that you should do is you should address this and try and address it on a political advocacy level. Find out about what current policies are pending. The Palliative Care Education and Training Act will be reintroduced to Congress. I think it has some bipartisan support, and they are saying it's going to be reintroduced in about 2 months. Keep an eye out for that and keep your ears open so that you can start influencing your legislators that you would like to see that passed. And often our most important role as practitioners and as people interested in cancer is to amplify the voices of our patients who can't be heard. And when you are dealing in a situation or you're approaching, ask yourself, who is not at this table? Who is not being served by this? And just the last piece of advice, because a lot of people say, oh, I don't want to engage in political advocacy, it takes too much time. A lot of things you can do take virtually no time at all. So right now you can make sure you're registered to vote. And if you aren't, you should go do that. And if you already did that, you should find out who represents you. And then one thing you can do after this webinar is look up who represents you and then go put their phone contact information in your phone. Because when policy comes up, you can start off your day and you can call those representatives. So, you know, very often as something is pending, I'm calling Schumer, Gillibrand, and Zeldin just to tell them what I'm thinking. And those numbers are programmed into my phone. So for when days you don't have much time, you could sign an online petition, just retweet something, like or reshare something on your social media. People do actually need that. Sign a pre-written email, talk to a friend about what you're thinking about. So then we can move into some stuff that's a little bit more challenging than that, but still pretty easy. Write an email on your own, send a letter or postcard to your elected official, make a phone call, or talk to more people about how you are feeling about current events. So a little bit more context, but certainly worth the effort. Make a telephone call, talk to 2 people, and also ask them to take action as well. identify groups that are doing work and maybe support them, maybe even see if you can financially support them, and donate money to a candidate you support that's going to be able to improve cancer care services. There are some things that you might have to actually leave the house for, volunteer for a candidate, attend public meetings, go to the offices, a little bit more difficult in COVID times. And then takes more time, but consider it anyway. Sign up to give testimony before legislative or decision-making bodies. Invite elected officials into your community to understand what's going on. Who can explain this better than you as practitioners and researchers and advocates? Or, you know what, why don't some of you just run for office, and who knows more about your community and what cancer patient needs than you? So thank you very much for this, and that would be it. I look forward to anybody's questions.
Thank you so much, Dr. Marmo, for that amazing talk. I think, again, we're going to move straight into the next speaker and save the questions for the end. I think there's a lot of awesome questions already in the chat, and I'm really looking forward to the panel discussion following Dr. Pirtle's presentation. So our final speaker, Dr. Jonathan Pirtle, is an associate professor at Drexel University's Dornsife School of Public Health. Dr. Pirtle is a policy dissemination and implementation researcher who focuses on issues related to mental health and health equity. His research uses theories and methods from the social sciences to understand how scientific evidence can be most effectively communicated to policymakers and translated into practice. Dr. Pirtle was awarded the Champion of Evidence-Based Interventions Award by the Association for Behavioral and Cognitive Therapies for his research related to dissemination of mental health evidence to public policymakers, and awarded Drexel University's Provost Award for Outstanding Early Career Scholarly Achievement. He teaches courses in implementation science and policy analysis, and is director of the school's PhD program in health services and policy research. Dr. Pirtle will now share his expertise with us in his talk titled The Potential of Dissemination Research to Promote Policies for Health Equity. Dr. Pirtle?
Thank you so much, and hello everybody. Thanks for joining. So I'm going to kind of, those presentations were wonderful. Thank you. I learned so much. So I am not a pain researcher at all. I'm an implementation scientist. I focus on dissemination and public policy, and largely mental health, and to some degree health disparities. I'm kind of going to bring this up big picture and just kind of want to highlight what I think is kind of the role of dissemination science in helping inform policy change around issues related to health equity. Okay, so my burning research question, again, I largely focus on issues related to mental health, but largely, I want to understand how. I'm focused on the how we can better translate high quality research evidence into public policy. So it's not just sitting on a shelf or on a server, it's getting to policymakers in clear and compelling fashions, and is then getting codified in laws that improve population health and reduce health inequities. So just real quick, what is dissemination research? So we have this field of implementation science, which I'm sure many or most of you have heard of. Implementation science is the science of translating how to translate research findings into practice. And we have implementation research and dissemination research within that broader umbrella of implementation science. And dissemination research is defined as the study of the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. So my research is really focused on policymakers, elected officials at federal and state and local levels, also in executive branch agencies, as kind of the target public health audience. And the intent is to understand how to best spread and sustain knowledge and the associated evidence-based interventions. So in other words, dissemination is really focused on communication. It's focused on how we can better communicate research evidence about health issues to different audiences. So I want to just bring in a little bit of David Williams here. David Williams is one of the major forefathers, I would argue, of thinking and researching about health disparities, and specifically racial health disparities in the United States. He wrote this article about a decade ago. But it's a great article that really kind of charts out a course of where we should be going to kind of translate health disparities research into practice. And a lot of things he says about 10 years ago are still true today. I just want to pull out one quote as kind of the impetus for the rest of this presentation. So Dr. Williams, in his article, he quotes W.E.B. Du Bois, who wrote this back in 1899, talking about African Americans in the United States. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such particular indifference. And Dr. Du Bois, seeing this indifference as really kind of the root cause of health disparities and the structural factors that drive the disparities. And I would agree that this is very much true today. And I think it underscores the importance, and as Dr. Williams says, we need to do research to really understand how we best can communicate about these issues to create the conditions for change, so societal conditions, political conditions. And when we unpack that and make it a little more concrete, two things I think we need to focus on is, increasing awareness about disparities and also the social determinants of health and health disparities. And that being, kind of cultivating a context that can help build more political will to address these issues and see more policy change. So with that, I want to present a little bit of data about health disparities and policymakers. So I'm going to structure this. I'm going to back up just a little bit. What I'm going to present is just 3 points from 3 buckets. And these 3 buckets fall within kind of this typology that we lined out for doing dissemination research. First, doing formative audience research to understand your audience, doing audience segmentation research to identify different important subgroups within your audience, and then dissemination effectiveness research, doing randomized controlled trials and really, teasing out which sorts of dissemination and communication strategies work better than others. And we wrote all about this in this paper. So if you want to read more, please do, and don't hesitate to reach out for the paper. So I just want to share 3 big picture kind of ideas or suggestions from the field of dissemination research that I think are important to translating research evidence about health disparities into policy change. So first, it's critically important to understand your target policymaker audience's knowledge and attitudes about the issue that you care about. And when it comes to health disparities in the United States, there is tremendous room for improvement. We see low levels of awareness about the existence of health disparities among the US general public. We even see this in the wake of the COVID-19 pandemic. There have been public opinion surveys. We see that these things that this lack of knowledge persists. And also we see this among policymakers. So here I just want to present a little bit of data. So we did a survey of US mayors and their senior staff and health commissioners and their senior staff in cities across the United States. So we surveyed about 130 mayoral officials, about 250 health commissioners, and we just wanted to get a sense of their knowledge and opinions about health disparities in their cities. So in this survey, we defined health disparities as differences in health between socially advantaged and disadvantaged groups, and we gave some examples. So we defined this very broadly. It wasn't focused on race or income or things of that nature. And we just wanted to get a sense among this target population of policymakers, what do they know and think about this issue? So this is what we found, and we were pretty surprised and struck by these findings. So only 42% of mayors and their senior staff strongly agreed that health disparities existed in their city, that they absolutely do. And even more surprising, only 61% of health commissioners. So these are the people in charge of health at a population level in these cities, and it was nowhere close to 100%. Fairly small proportions thought that these disparities were very avoidable. This more understandable because research tells us they are avoidable, but maybe they were thinking about kind of the political will and what would need to happen to change them. We asked them more of a value-focused question about the extent to which they thought disparities were fair as we defined them. And only about a third of mayoral officials thought that they were very unfair, and only about half of health commissioners in these cities thought they were very unfair, which we also found very surprising. And lastly, we asked them about the extent to which they thought that city policies could have an impact on health disparities as we defined them. Only about a fifth of mayor respondents thought that city policies could have a major impact, and also less than half of health commissioners. Even more troubling, perhaps, among mayors, about a third said they thought city policies could have little or no impact on health disparities in their city. And while, city policymakers are limited in their authority, there's preemption from the state level, there are a lot of factors. There are a lot of things that cities can do to reduce health disparities. And among health commissioners, 8% thought that city policies could have little or no impact. So this is kind of just showing, where these policymakers are at with their knowledge and opinions about health disparities. And from a dissemination perspective, the so what of all this is it shows us kind of where our audience is at and thus how we might communicate with them to meet them where they are at. Here we stratify the data by the ideology of the respondents. We ask them about their social as well as their fiscal ideology on 7-point scales. We created this composite measure of ideology, and we can see tremendous and statistically significant differences in the mayor sample and also in the health commissioner sample when it comes to their knowledge and opinions about health disparities. We were very surprised to see this among the health commissioners, again, because these are the folks in charge for population health within the cities. And these data just kind of, show that, a person doesn't check their ideology and their worldview at the door when they're a policymaker. We still see these differences in kind of policymakers that are in career roles as opposed to elected positions. So in the survey, we also asked about, the extent to which these policymakers thought that different factors influenced health disparities. We really want to get a sense of the extent to which they were familiar with the social determinants of health, the role of housing, education, and income, and psychosocial stress in producing health disparities as we define them. And again, we see lower levels than we would really hope to see. And also we see these strong differences by ideology. And again, all of just saying, this is where this audience of policymakers is at, and this is useful information to have when communicating with them about issues related to health disparities. Again, we see similar patterns among mayors and health commissioners. So that was the first big point. Understand your audience. Then this realm of audience segmentation research, thinking about how different messages might be more or less effective for policymakers with different opinions about health disparities. So there is a field of study focused on audience segmentation, identifying different subgroups within a larger population, and then doing things called message tailoring to understand how you might craft different messages for folks with different attitudes and different knowledges, different states of knowledge. So I just want to call out and give a very brief example from a very cool study relevant to health equity and communication. So this was a study by Larry Bai and colleagues published in Health Affairs about 5 years ago. Really big public opinion survey of about 10,000 US adults. And they wanted to get a sense of, are there different groups of Americans when they think about issues related to health equity? And they use this statistical approach called K-means clustering, where you look at how different variables hang together. And they identified these 6 different segments. And I won't talk through all of them, but as you can see, they range from the disinterested skeptics that don't think that the government should have a role in anything really health related. They also don't really care about their own health that much in general. And then in the other quadrant in the top right, we have the committed activists who think that, government should do a lot to promote health and promote health equity specifically, and personally care a lot about health. And this is just to illustrate, there are a lot of different groups, and a one-size-fits-all communication and messaging approach is likely to be less effective than a messaging and dissemination approach where messages are tailored for different subgroups within a larger population that you want to persuade. And then lastly, very broad macro point, but when we think about policy advocacy and policy disseminating evidence to policymakers, I think we often just do what seems to make sense, and we think that some action is better than no action, and I completely agree with that, and I agree with all the wonderful points the last speaker said about calling your congressperson, sending emails. All of that does matter. But what I think it's interesting, we do really rigorous and systematic science to generate information, to understand the existence of health disparities and how we might ameliorate them. But when it comes to disseminating these findings, we're not really using a research-based or a data-driven approach. So I think there's really a need to empirically test different strategies to communicate with policymakers. about these issues and really just kind of bring our A game and not just, stop bringing our A game when we're done producing the primary knowledge about health disparity issues. We need to carry those kind of research approaches forward to really understand how we can best communicate about these issues to policymakers. Just throwing up 3 examples of randomized, controlled, very rigorous, high quality studies, all of which have focused how to better get research evidence into policy-making processes. So testing different policy briefs, including a map, not including a map, including a story in a policy brief, not including a story. Understanding the effect of, making connections between researchers and policymakers and sustaining them over time and seeing what kind of outcomes we get. So all this to say, I think we really just need to do rigorous research to understand how to better translate research into policy and not just stop bringing our research A game when the primary original studies are done. And lastly, I'll conclude by stating the obvious, but by stating it by somebody who put it very, very eloquently, that policymaking is political, and that's just the way it is. And it's important to keep that in mind when trying to translate research into policy because it is what it is. It's a quote from Carol Weiss. Dr. Weiss was kind of one of the early scholars in the United States who really focused on this issue of translating research findings into public policy. This is a quote from one of her papers. The policymaking process is a political process with the basic aim of reconciling interests in order to negotiate a consensus, not implementing logic or truth. The value issues in policymaking cannot be settled by referring to research findings. And we see this play out in the real world in front of us as well. And I think it underscores the importance of, taking policymakers' values into consideration and the general public's values into consideration when developing strategies to best disseminate research findings to have the most impact. So with that, I'll stop and thanks for listening.
Thank you so much, Dr. Pirtle, for your awesome presentation. Everyone, ended on time, so we've got lots of time for a good panel discussion. I'll turn it over to Dr. Sandy Mitchell so that she can lead this part of the Q&A.
Great. Well, thank you so much, Dr. Acevedo, and just a warm appreciation to 3 excellent panelists for 3 great talks, and they just synergize so beautifully. We're getting some questions coming in via the Q&A, and please continue to put those forward. And while we're waiting for more of those to come in, we have had a few questions already coming along. So I think we'll just kickstart with some of those here. So one of the questions is that this idea of total pain is quite intriguing, and we're interested to hear a little bit more from each panelist about how would you recommend that researchers studying pain measure and operationalize this construct? Is it just a matter of combining different measures of each aspect of pain, like interference and anxiety? Are there any formal measures of the total pain construct? Sort of what measurement development needs to happen in that space? And I'll maybe invite Dr. Magani to get us started with this, followed by Dr. Marmo and followed by Dr. Pirtle.
That's a very interesting question, and the term was obviously coined by Dane Cecily Saunders, modern palliative care movement. I am not aware if that concept, because pain is such a complex concept, and the biopsychosocial. I'm not aware of any measures that adequately capture total pain, but that is something that is food for thought. But I do know that we have constructs that measure different aspects of pain, but I don't know if there is a measure that combines that.
Yeah, that's a great question. Again, I just did some quick research because I saw the question. I'm not aware of one measure that captures all of that. However, the different, as Dr. Magani was saying, the constructs of total pain, there is a valid and reliable measure of spiritual pain, some very often used by nurses in an assessment. And there are obviously a lot of, the GAD-7 right away can assess for depression and anxiety. There are scales called financial toxicity scale to understand a little bit more about social. And then the American Cancer Society, to be a designated cancer site, there is a screening tool that patient navigators have to do as well. And that does capture some stressors. But as far as total pain, I don't know of one measure, but that's an excellent idea.
So as a non-pain researcher, I'll take this question a little bit differently, and kind of, I guess, how I would see that construct playing out in a kind of policy advocacy sort of way. I think so. The research evidence tells us, I mean, when you're communicating about any issue, narratives and stories matter, and they're really, really effective, and also more effective than data, and they can complement data. And I can imagine, in terms of the construct of total pain, a story or a testimonial from a person who's experiencing pain to a policymaking body to kind of shed light and elucidate kind of all the different dimensions of pain across those different dimensions could be effective in kind of cultivating policies maker support to do something about that issue and kind of open their eyes to kind of pain as something more broad than they have conceptualized that as a policy issue.
If I may, I would like to add something, Dr. Mitchell. So one of the challenges in measuring these important constructs is, in the research setting, we measure a lot of constructs using the classical test theory model, which is very in the clinical setting. We are not able to translate a number of those measures because of the time it would take for them to be materialized, to be elicited. I think that the item response theory model, if there were to develop a total pain measure, the item response theory model, measurement model would be very useful in developing those brief tools for clinical use.
And just one other thing to add is that traditionally pain assessment in the clinical encounter is focused primarily on physical pain. So when we ask someone on a scale of 1 to 10, can you describe your pain? The inference is that that's physical pain. And if you're not asking, then people aren't going to tell you. But we do know that stress can cause a greater pain response. But we're not asking those types of questions.
Thank you all. It was really, really interesting. And Dr. Magani, very interesting that you're mentioning item response theory, or IRT. And I think I was having a similar kind of thought during the comments about measuring total pain, and just want to point out that the PROMIS measures do have a lot of different dimensions and elements that could perhaps be built upon to kind of create that item bank that could be then utilized for that IRT-driven total pain assessment. So very, very interesting. This question is also kind of an interesting one, and we're having a number of comments coming in about the issue of access to multidisciplinary specialty pain management clinics, and also access to multidisciplinary and specialty pain services. Certainly, Dr. Marmo spoke about this a little bit in terms of, Dr. Magani, and acupuncture. Physical therapy is another aspect, and then certainly psychological and social work and mindfulness training and all of those other complementary and integrative health pieces. And so I would be interested for each panelist to just sort of touch on additional barriers and then additional policy levers that might be able to be utilized to reduce some of the barriers in access and use to that sort of full multidisciplinary range of services, including the specialty pain clinic, because that in my own clinical practice has also become, there's some new barriers with that, with sort of the advent of the opioid epidemic and the CDC guidelines. There's been some additional hurdles produced there. So I'm curious for each panelist to kind of address this issue of access to specialty and multidisciplinary pain management interventions.
Thank you, Dr. Mitchell. That is, I think, one of the major questions and challenges. I think at least for cancer pain, I think currently there is a mirage of access that is created for at least patients who are receiving active cancer treatments. They are excluded from the scope of certain guidelines, etc. Cancer patients are consistently excluded from state policies. They are consistently excluded from studies of longitudinal outcomes of certain interventions that are being studied for chronic pain. So why am I saying all of that? Because the overt access or opioids have access to something. I mean, barring all the difficulties I articulated about the at-risk groups. However, as I said, patients do not use opioids consistently, and they do everything not to use opioids. At the same time, they don't have access to non-opioid, non-pharmaceutical treatments. So this is the mirage of access that we have created. Now, I think in terms of policy levers, one thing could be messaging. We know that pain is the #1 reason for healthcare utilization. I also showed my data whereby inconsistent opioid use is also a strong predictor of unplanned healthcare utilization. And in our center here, the New Cortland Center for Transitions and Health, we have other researchers who have independently found that opioid use is a predictor of unplanned healthcare utilization. And we have found with cancer patients inconsistent opioid use. So I think the messaging could be that we know that unrelieved pain increases healthcare utilization and therefore burdens on the insurance companies and payers. So maybe there needs to be this idea to make the non-opioid, non-pharmaceutical, pharmacological treatments mainstream. I think currently they're not considered mainstream. And I think there needs to be additional work to convert them into mainstream, and that would only occur when the research that is going on. So first of all, paying homage to what we already know, and then the newer research, they should not just focus on biologics or pharmaceuticals, but also focus equally on the non-pharmacological pain interventions.
I mean, as far as access, I think it can come down to two simple concepts. Like, one, can I afford it? And two, can I get there? So can I afford it? So that's where disparities come in. People of lower socioeconomic status or who lack insurance are not going to be able to afford adequate pain control for their cancer. Copays are very expensive. One of the things that does help is when a patient is referred to hospice, any medications that are related to the reason that they're on hospice are covered. So they can get their pain medication covered under their per diem hospice benefit, maybe with a small copay. I think that's been implemented recently. So that's one thing. I think there is a low utilization of palliative care, and palliative care for a cancer patient working concurrently, I think, could be very helpful, but we would have to change the policy benefit under palliative care as well. But that idea that it comes under a per diem benefit and is part of your total care, I think is very helpful. But again, that's not always available for patients who aren't on hospice because of the other problems with cancer patients being on hospice, not being able to pursue any type of curative treatment. And you can actually find in hospices, cancer patients are the most expensive to have on hospice because the levels of care are more expensive than other illnesses. So you actually see this with for-profit hospices and non-for-profit hospices. For-profit hospices are less likely to have cancer patients than non-for-profit hospices. And so when we move into like, can I get there? Specialty pain clinics sometimes are not in rural areas and are not in, underserved areas. One thing that did happen with COVID is telemedicine. And one state policy that was enacted in several states was the removal of the face-to-face encounter need for prescribing opioids. That is usually a requirement, is that someone needs to be seen face-to-face. But in several states that has been lifted, but only temporarily for prescriptions of opioids. So a telemedicine can do that. So that's one thing that could help is keeping telemedicine in place so that we can reach those people that are maybe not in an urban or suburban center that has a pain management or palliative care available.
Yeah, again, I'll take this question a little differently, not knowing a ton about the issue. But yeah, in my research and the research of others with policymakers, cost and economics matter a ton, and budgets matter a ton. So I think the more that, one could make a strong empirical case for, increased access to specialty care, better coordination can save money for an entity, that could be a compelling policy argument. The tricky thing with cost-related stuff is, often something that saves money for one entity takes away money from another entity, right? Because that money is being spent. So it could save money for Medicaid, but then there are health systems getting paid less dollars. So it can be challenging to find that sweet spot that is appealing to kind of all the major political players that would be involved in this issue. In this context, right, state Medicaid directors, insurance companies in states, major healthcare systems in states will all have kind of a perspective on this that is aligned with their interests, and those can be in conflicting oftentimes.
Thank you, Dr. Pirtle. And that's so important to understand sort of what are the pushes and pulls here, because there definitely are push and pull factors. I'm curious, just on this same topic, we're getting some questions though coming in about what should be some of the priorities for research collaborations to strengthen those research collaborations between pain researchers and individuals who are studying cancer pain as a subspecialty? Are there some areas that are particularly ripe for research where we should be kind of advocating for some research policy in those spaces, or other kinds of research policy just to strengthen that collaboration between specialty pain and cancer pain researchers? Any thoughts about that, particularly Dr. Magani?
I think that one thought, maybe not directly related, but as I was alluding to before, cancer patients are a consistent exclusion criterion. If you have cancer, you are consistently excluded. I mean, just pick up literature on chronic pain, a lot of investigations that have been done. It would be non-cancer chronic pain, which has rendered the situation where we don't have a whole lot of literature on longitudinal outcomes in patients with chronic pain. If you look at CDC guidelines, blatantly absent. So I was recently looking at NIH HEAL, one of the RFAs from NIH HEAL, and it had also cancer as an exclusion criteria specifically. And I was almost worried a little bit that are we replicating in a way that we are going to generate a whole lot of body of literature that's not going to apply to cancer patients again. So I think that there are opportunities because there is a whole lot that researchers have learned in specialty pain management, in chronic non-cancer chronic pain management that could be partnered and learned from to develop this more holistic and more extrapolable, if that is a word, findings for that benefits cancer patients also.
Great. Thank you. That's extremely helpful. There's just so much work to be done in this space. That's very exciting to have this opportunity to focus on that. I want to turn our attention a little bit to some of the issues. There were many references made to racial disparities around opioid use. And I guess I wonder, are there differences in those disparities by cancer type, or are there any known individual differences that any of the panelists could talk about with respect to race, ethnicity, or gender, or genomic variations in opioid metabolism genes? So I think it'd be interested to hear, this is related to several questions that we're getting. Also, are there subgroups at greater risk for having issues around abrupt and rapid discontinuation of opioids? So kind of talking a little bit about some of the individual differences as well as disparities driven by some of those underlying factors. I don't know if Dr. Marmo, you want to start us off with that?
I do know that the research does tell us that certain types of cancer are more are a greater risk in certain populations. I know breast cancer and prostate cancer amongst African Americans are much more likely to experience pain and also to be fatal amongst that population. Yeah, I mean, a lot of my research is around the social conditions, not necessarily the physical connection.
Any thoughts, Dr. Magani, about
Yes,
those,
yes, that's
disparities?
been my research. So a lot of research that we have done on this topic. I think that there was a meta-analysis. I can't tell you the author's name right now, but the conclusion was that the polymorphisms, etc., that occurs in terms of opioid metabolism, those are not the key drivers. The key drivers for disparities, the clinical disparities, are either access or how pain is managed in subgroups. So for instance, one of the articles I showed you on the slide, African Americans are more likely to receive an analgesic with toxic metabolites despite clinical risks. This article was published in JCO in 2014. Basically what we found, there are a lot of myths around how pain, like Dr. Marmo very well alluded to that this 2016 study by Hoffman and colleagues, it found that we have a lot of biases and stereotypes about how pain is perceived by racial ethnic subgroups and especially Blacks. So we found that there was another myth that I've heard a whole lot, that patients, African American patients, and in this study, we used mediation analyses to first show that yes, in the direct effects, African Americans had more adverse effects from taking opioids. But in the mediation analyses, the direct effect completely disappeared. And all of the effect was mediated by the type of opioid that clinicians prescribed. And in this group, patients were prescribed morphine. Blacks predominantly were prescribed morphine despite having renal insufficiency, which you know that the toxic metabolites accumulate in the presence of renal insufficiency. So obviously they'll have more adverse events. So one of the key take-home messages that I would like to maybe impart using this important forum is first look at more blatant clinical explanations before jumping to biology or other sorts of mechanisms. And usually in terms of effect size, which is the magnitude or the size of effect that a variable has on outcomes, your clinical variables will explain more disparities than these other variables.
That's a really important insight. And you mentioned renal dysfunction as being, one individual variable. I imagine that comorbid conditions is another. Do you have some candidate covariates from a clinical perspective that you think are probably potent and important to accommodate in these analyses?
For us, a type of cancer has never panned out for our research. For our research, also, I'm talking about disparities in pain outcomes. And we have also studied adherence outcomes. Biological sex, and I know that biological sex is an important variable in many, many different outcomes, but for our research that also has not panned out. In our research for Blacks, and we did one research where we identified independent factors that related to patients' adherence to opioids, the prescribed opioids. And the most strong variable was income for Black persons, but that variable was not significant for whites. Dr. Marmo mentioned about distracting physicians and clinicians. That was an independent variable that has explained a number of things in our studies for Blacks, but not for whites. So there are variables that have explained these outcomes more so than other clinical factors for us, at least.
Yeah, I think draws attention to, social determinants of health are really an important piece of trying to understand mismanaged disparities in pain management, that those are really strong contributing factors. And I'm also wondering about substance abuse and, previous substance abuse, the impact of that as well. I haven't seen much research on that.
And that actually nests with an interesting question that came in. It's a narrow question, but I think an important one. Could panelists kind of comment on the role or place of measuring opioid use disorder in the context of cancer pain management studies? One of our participants here in the audience has said that they are frequently given that feedback at review that they need to be measuring opioid use disorder, and they're really struggling with where that should fit in their study design. Are there any thoughts about that?
Yes, that's a great and very relevant question. In our current R01, we are measuring the current opioid measure, the opioid risk tool, and you definitely, you definitely need to account for a potential. There are variable estimates in terms of the prevalence of opioid use disorder amongst cancer patients, but there is a minority that has concurrent opioid use disorder and pain. So there is a phase to measure it. We are measuring it, and we are using it as one of the moderators in trying to understand the relationship between our independent and dependent variables, which is patient-reported outcomes and healthcare utilization. So, so just to answer that question directly, we are using it as moderators in our study.
I think that there's some particular challenges when trying to study, for example, interventions to help people better advocate for their pain management needs. There really can, that's part of the stigma that has been already talked about in the presentations. If you're urging your clinician to change your prescription, give you more, better manage your pain, the intersection of that with a perception of drug seeking can be very, very challenging. I want to turn our attention to some questions that we're getting about the really intriguing sort of juxtaposition in these panel presentations of the challenges that have been experienced in the uptake and implementation of the CDC guidelines. And Dr. Magani, you gave an excellent overview of some of the challenging ways that that has been taken up. And then Dr. Pirtle, you provided, I think, really some terrific ideas about the dissemination process and how we need a much more data-driven approach to that. I'm just curious to have all of the panelists really address this issue of, you know, with hindsight, are there some issues and considerations around guideline dissemination that might have been mitigated with the CDC guidelines? For example, they had an overly broad title. I'm not sure if they had a period of public comment, but I think what kind of dissemination research techniques might be applied as guidelines are being developed, as their plans for adoption are being formulated? Are there features in guidelines that should be more consistently taken up? And I guess I would turn to Dr. Pirtle first to kick off a discussion of this topic.
Yeah. So guidelines are interesting, right? Because there's a very standard and widely adhered to systematic process for developing the guidelines themselves. In terms of literature review, and there are, you know, international standards for guideline development, which I assume the CDC adhere to in this context as most entities do. But then in terms of how you package and disseminate the guideline, there's very little guidance, right? So as you said, the title, for example, how the guideline is laid out in a PDF or different sorts of web-based modules about the guideline. All of that, the entity that develops the guideline has a tremendous amount of discretion. So I think one point of guidance would be, I think what often happens is, you know, an expert process, experts are engaged with to develop the guideline, but I'm not sure how much they're engaged with to make decisions about the packaging and then distribution of the guideline. And we can think about, you know, user-centered design principles and kind of engaging the end users of the guideline, not in the development of the guideline itself, because that's really driven by research evidence, but in terms of how it's packaged and how it's put out there, and doing some pilot testing and things like that to really kind of have, you know, products that we think are going to work well with the target audience. And then again, right, you can, you know, package the guideline and send it out in different ways. So there's a great study by a colleague of mine, Zach Mizell, who's at Penn. He was actually really focused on the National Association for Emergency Medicine Physicians, ASEM, I think it is. They had an opioid prescribing guideline for emergency medicine physicians. And he partnered with that professional society to do a randomized controlled trial where they tested, you know, the society disseminating the guideline in a really standard format, which was just, hey, here's some information about the guideline, versus one that was really narrative driven. So it was focused on stories from emergency medicine physicians about their challenges in opioid prescribing, and then the guideline itself. And their outcomes were things like email view and link click rates, and then signing up for state prescription drug monitoring programs and things like that. So there's definitely a role and examples of how to bring in research approaches to guideline dissemination and packaging.
I can comment also a little bit. Those were excellent points. I think the fundamental question is whose obligation it is to monitor and address misapplications. That's the fundamental question. So for instance, I'm a clinical researcher, right? If I do research, I have obligation to my patients. I prepare sometimes 20-page, extensive consent forms, informed consent, and what they are, signing up for. So, and I'm doing a clinical research with 400 participants. Then you're talking about a guideline that is potentially going to affect 30 to 50 million Americans. So I think that that is the first question. I have proposed, and I've proposed elsewhere also, that the guideline authors should be responsible for co-developing a plan for risk mitigation, where they anticipate, similar to research studies, you anticipate that these are going to be the potential risks and harms, and you have measures to anticipate it. So I think that's the first point. The second point, I completely agree with Dr. Purtill that we need patients or the end users, and not only clinicians, but in terms of conceptualization, we need patients who are going, look at Twitter and look at, social media and look at where these, the chronic pain patients are voicing their concerns because they don't feel heard. So those are the patients who are going to be affected. Should be, this is PCORI type model, and this is NIH model. Your patients should be, the stakeholders should be part of those conceptualizations. I think I'll stop here, but there were some other, from the research itself perspective, just to give you one example, that the American Society of Clinical Oncology guidelines came out essentially at the same time as the CDC guidelines. Both came out in 2016. Even though cancer survivors were included in the CDC guidelines, the ESCO survivorship guideline drew on a completely different, not completely, but overarchingly a different body of literature than the CDC guidelines for cancer patients. So I think there are opportunities to talk in terms of lessons learned, to talk with the professional oncology societies and people who have been doing this for a long time, to learn, and having those people on the table as well.
One thing that I noticed when I review, CDC guidelines for prescribing is that we have all of this evidence of disparities in pain management. And we also have all this evidence that people from marginalized communities have difficulty and do not trust their providers, and that also providers are misjudging pain. But there's nothing in the guidelines about how to sensitize and how to incorporate cultural humility into providers' practice. So that seems to be missing from all of these approaches, and I question, like, how are these guidelines adaptable to all populations?
That's an the populations, at-risk population, there was not a deliberation of how to mitigate those risks, and some of those risks were predictable.
Well, we're just about to wrap up, but I would like to give each one of our very dynamic panelists one final opportunity for a quick 15-second or less comment. One policy change that you would like to see implemented that would narrow the gap in cancer pain outcomes. And I will start with Dr. Purtill.
So it's anticlimactic, but I think I'll pass. As being a non-pain researcher, I don't think
Okay.
I have a strong opinion or perspective to offer here about what the policy magic wand should do. So I'll pass, but I guess my final thought will be, when communicating with policymakers about this or any issue, just importance of, taking into consideration kind of where they're at and their baseline knowledge and attitudes and thinkings and values about the issue, and kind of taking that into consideration when crafting a message for your policy ask.
Wonderful. Dr. Magani.
All right, I'll just say that I think that there are opportunities, like Dr. Patel said, about understanding. So first, and then there are epidemics within epidemics. So the opportunity really is to tease apart that you have three different groups here. You have patients who need opioids, absolutely. The policy directions for those would be different from you have patients who have concurrent or they have opioid use disorders. They have a different set of directions. Absolutely, I think we have a national crisis in terms of access to medications for opioid use disorder. And then the third group is opioid naive patients who obviously you want to limit their exposure, but at the same time, you want to provide them with workable alternatives. And I think workable alternatives, non-opioid, non-pharmacological interventions, I think that's where we want to go. But there are these different segments that ought to be understood and then addressed accordingly.
Thank you. And Dr. Marmo, you have the last word.
I would like to see us stepping away from fee-for-service medicine, specifically with the needs of cancer pain being probably better addressed as a total pain model, which would require an interdisciplinary team. And I'd like to see upstreaming of palliative care so that curative treatment and palliative care can work concurrently and maybe look the same as the hospice Medicare benefit.
Wow, I cannot think of a better talking point on which to end. And so I will just turn it quickly back to Amanda, who's going to tell us about close out the session.
Actually, Dr. Ferrer will do that. Dr. Ferrer?
Oh, I'm sorry.
It's okay.
No worries. Hi. So I just want to thank all of our speakers and panelists. This is a really great session. I want to thank Amanda and Sandy for planning all of this and all of our attendees. This webinar recording will be posted within 2 to 3 weeks. This is a series, so there was a webinar. The first webinar in the series was about a month ago, and that recording is available if you've missed it. The next webinar in the series will be in May. The date will be TBD. And there is a related webinar listed at the bottom on disparities and barriers to pediatric cancer survivorship care on April 20th. So with that, just thank you everyone for a really great session, and thanks for everyone for attending.
Thanks everybody. Have a great rest of the day.